right, so this is actually only the second semester we're running this program at FIT, and it's sort of giving a little bit of public health focus into our health professional training. And if anybody, after listening to all these presentations and wondered how you can join, and just email me. So anyway, just a little bit of overview of the program. Students actually learn a strategy, sort of a problem solving strategy in public health, and then adapt that to patient-centered care. And we want to raise the awareness of public health issues. And a lot of time when you treat your patient, you're not only dealing with the medical problem, it's also, looking at the entire person, the environment they're living in. It's a lot of other issues going in. So without further ado, let's welcome our first team. If you don't mind, just introduce your members before you start your presentation.
Sure, we'll go in order. So hi, everyone. Thank you for joining us today. My name is Anika Rahman. I'm an OMS2 in the Osteopathic School of Medicine.
My name is Sarah. I'm a senior undergraduate med bio major with a minor in public health.
Hi, I'm Kira. I am a first-year student at the College of Osteopathic Medicine.
And just one note, if you can, feel free to turn on your video. We love to see your face.
Leaving home with broken bones, a case reflection. Our case is about a woman named Barbara Smith. Ms. Smith is a 63-year-old white female who identifies as cisgender living in Lewiston, Maine. She presents to the Central Maine Medical Center Emergency Department in Lewiston, Maine for COPD exacerbation and told the nurse she is being evicted at the end of the month with nowhere to go. Her past medical history includes seasonal allergies, an appendectomy 45 years ago, COPD exacerbation 3 times in the past 6 years, a 30-pack year tobacco use, which ceased 5 years ago, chronic back pain from an MBA 10 years ago. She uses a walker, and she has a family history of COPD, hypertension, and mental illness.
The health, behavior, social, and environmental factors within Mrs. Smith's life have all had an impact on her case. This framework gives us an aerial view of the positive and negative factors. In the red are the negative, and in the green are the positive. The complex interplay between each of these factors creates the matrix of Mrs. Smith's reality. Her most impactful negative factors included poor diet, isolated living, and food and housing insecurity. Her greatest positive factors are her faith, her church friends, and her ability to join Medicare. Our goal is to unravel these threads to minimize the negative influences and enhance the positive ones. And we will show you how we plan on doing that in the next slide.
In coming up with the solutions for Ms. Smith, we triaged the problems in order of priority. First, Ms. Smith should be admitted to the emergency department for her COPD exacerbation, and a chest x-ray is recommended as her last one was 3 years ago. Next, it's important to schedule a PCP follow-up appointment for medication management. She may need additional tools to manage her COPD given the recent exacerbation. Given the progressive nature of her chronic back pain, a PCP is best equipped to tackle a conversation about lifestyle modifications. This is to be scheduled while Ms. Smith is at the ED so that this important appointment does not fall through the cracks. OB-GYN referral should then be made for a mammogram given her heightened risk. Next is to tackle the problem of eviction and housing insecurity. This is where social work joins the team. First, it's important to understand that Ms. Smith qualifies for Medicare, and social work can help set this up. Then, it's important to provide her with housing resources. Some housing options in Lewiston include Lewiston Housing, Maine Housing, and if she qualifies, assisted living options. Utilizing one of these services can provide her with housing and the nearby resources that come with this relocation, while still allowing her to continue to stay in her Lewiston community. Social work can also sign Ms. Smith up for Meals on Wheels services that she has a safety net for food. Next is to set up physical therapy appointments for management of her chronic back pain. This might need to wait until she has Medicare in place. Last comes dietitian counseling to help improve her diet in order to better manage her hypertension and weight. It's evident that all this will take a team to accomplish. The next time a Ms. Smith walks into an ED, consider the tools you have at your disposal, not only for acute management, but also for the patient's long-term success.
All right, we're open up for questions. Feel free to ask the team anything, their experiences, surprises, or specific to the cases. So maybe I'll start one question, sort of a overarching question. After working through the case and then looking for the resources, what's the most surprises you guys got?
I think for me, it was Well, first of all, it was pretty fun to look for resources that, are very community specific. I think it made me reflect on the fact that I don't know what my own resources are in my own community. And I imagine that a lot of patients wouldn't know either. So to have someone there to kind of do that work with you is very important in a patient's care so that they understand that, the communities they live in can give them the support they need if they know where to look for it.
That's a really critical, right? Looking for resources, because a lot of time when you're facing a patient and you only focus on their medical problem, and then you tell the patient you need to have a better diet, you need to exercise, and then you don't know what's their environment and the why they are not exercising. And a lot of time it's not like they don't want to. There's the circumstances around them. And then when you tell people to look for resources, and not everybody even understand a lot of terms. And know where to go. I mean, just in rural Maine, computer access, internet access, it's not always given. So knowing a little bit yourself, it's really helpful. And you know how hard it is, and certain things, it does not just come easily. So hopefully this experience helps you to help you navigate your patients in the future.
Hi, everybody. Michelle Polachek. I'm so sorry I was late. But this is an interesting conversation. I have in the past worked with family practices and pediatric practices that put together resource lists for their providers. It's not always easy to do, but it's really so helpful to have that as a provider to turn to when you have a patient who clearly needs support. So I just wanted to add that.
So great to see you, Michelle. I'd love to have a more public health students and the faculty join our program as well.
Well, thank you all for listening.
Thank you. So by the way, I didn't say the program at the beginning. The case is actually sort of generated by the students. So students have opportunity to be creative because most of the cases we use in class or we see doesn't have a lot of details. Not the medical side, but where they live, what kind of resources they have. We actually task the students to create their own case. So give the patient a location, and then they'll be able to go in to find the resources for that area. All right, so I think this is team 3. If you don't mind to introduce yourself before we start the presentation.
Hi,
Oh,
sorry,
go.
I was just gonna go in order, sorry. I'm Rachel Bordenaro. I'm a first year student at Unicom.
I'm Diana. I'm a part of the accelerated nursing program, so I'm just in my first semester right now.
And I'm Stephanie. I'm a second year comm student as well.
This semester, we participated in the FIT program, in which we developed a patient-centered framework for a fictional patient. With our interprofessional team, we adapted the public health problem-solving paradigm for root cause analysis and patient-centered intervention development. Our fictional patient is Mr. James Libby, who is a Vietnam veteran with a recent stage 4 colon cancer diagnosis. Mr. Libby is struggling to accept his new role as a patient because he's always perceived himself as a strong provider and does not want to be dependent on others for his care. He has an extensive medical history, which adds to the complexity of developing interventions for his case. He has a family history of colon cancer that predisposed him to developing his current diagnosis. He also drinks alcohol, smokes tobacco, doesn't exercise regularly, and recently his wife passed away as well.
This framework is intended to illustrate the various factors that impact our patient in their new diagnosis of colon cancer. We can see both positive and negative impacts that his environment contributes to the diagnosis. Here we are showing the individual negative and positive factors that Mr. Libby faces.
These are his risk factors and the things that make it difficult for him to adjust to his new diagnosis. His wife passed away from COVID. His father also had colon cancer and died from it. He receives all his care through the VA hospital only, and he has to drive himself to anywhere he needs to go. He has to deal with social stigma associated with having been in the Vietnam War. And also a recent study done found that there's a phenomenon among Vietnam veterans where declining physical health and loss of loved ones, both of which Mr. Libby is struggling with, have been associated with late onset stress that diminishes resilience and can cause further health decline.
So I'll be talking about positive factors that affect Mr. Libby's care. In terms of his interpersonal relationships, he has a son who lives nearby who he can rely on for support, as well as one healthy older brother who lives in Florida. In his community, Mr. Libby lives in a quiet neighborhood and is socially active. Specifically, he attends a Unitarian church, he's a member of the Veteran Social Group, and at the VA and utilizes veteran services that are offered. Also, he volunteers as a greeter at the Togus Veterans Affairs Hospital. Societal factors that affect his care is the fact that he's a white male, which means he's a part of the majority demographic group. This slide just shows an overview of all the positive and negative factors in the public health framework that we've discussed. We wanted to make sure that our interventions were patient-specific that allowed Mr. Libby to take control of his current diagnosis and his healthcare needs. We'd like him to reach out to VA provided resources such as the Fisher House Foundation and the Hero Miles program, while also taking care of his diabetes and obesity with a nutritionist. We believe a social worker would also help him get referrals to community resources.
Anybody have any questions for the team? So I'm sure the team has looked up for resources, a lot more than what they put on the slides. If you guys want to elaborate a little bit more on the resources that you have fun, that would be great. Rachel, Stephanie, Diana, are you still
I
there?
think I'm confused by your question. What do you mean, like resources, as in like interventions, or resources that we use to find the information for the case? Or
I was just thinking about resources you found for the patient. As you mentioned that there's a lot of local community resources, but you can elaborate on both because that would be helpful too, knowing where to look.
Okay, I can go into that. So, I am a current second lieutenant in the Air Force, and I also volunteer at Togus every now and then in Augusta. That was part of the reason why I chose this case. So Fisher House Foundation is a resource that the VA and the military provides to veterans. That is a house basically right next to VA hospitals that allows their families of veterans to stay at while their family members getting care at the VA hospital. And then the other one that we mentioned was Hero Miles program, and that's another military funded program that would allow Mr. Libby, our patient, has a brother that lives in Florida, so it would give his brother the miles to fly from Florida to visit him in Augusta. And both of these programs are available to the veterans that utilize the VA hospitals. And then outside of those, we also talked about consulting a nutritionist or a dietitian to modify his diet. He lives in Augusta and he is able to drive himself, and he lives about 5 miles away from the closest grocery store, but we want to make sure that when he does make it to the grocery store that he's choosing the right food options for his diet or for his health needs, and then also connecting him with a social worker to help with transportation service if that becomes a future problem for him, since he is an older individual and things are pretty far away in Augusta. They're not like it's not a very condensed city. And then also probably to consider meal or grocery delivery services that Hannaford does provide. And then since he does suffer from PTSD, maybe a psych evaluation would be beneficial for him to, come to terms with that reluctancy that he has, or that negative outlook he has towards healthcare and getting healthcare services done for him. And then also a colon cancer support group. There are plenty online and that we could find for him either locally or nationally that are, very active. So those were the options that we came up with for him.
This is great. So Rachel, do you want to add where you guys start to look for the resources for your patient? From the hospital website or any public links?
There were 2 case studies that Stephanie had found in different databases that I went into, and I looked at specifically what the the HPI looked like for those two cases, and then I based the HPI for our case around that, and kind of the symptoms that I read based on those two case studies, I kind of like combined them together to get our fictional patient's HPI, so that I had a realistic kind of, because I don't know much about having stage 4 colon cancer, so I just wanted to make sure that it was an accurate representation of what someone who has stage 4 colon cancer would be experiencing as they're going to get diagnosed with it.
That's great. Michelle, I don't know if you want to chime in. I know you worked with a Hannaford about the nutrition program.
Yeah, so I have so many thoughts running through my head as I'm listening to this. It's such a complicated issue, and chronic disease is so clearly underlie, I mean, nutritional issues underlie most of our chronic diseases. So Hannaford has a lot of resources for patients. I don't know if you're aware, but they also have all these virtual resources available for folks. Not only do they have dietitians in their stores, but then they have cooking classes and all other types of virtual resources available for anyone who just wants to tune into those. And I didn't even know about half of those resources until recently. They also use guiding stars. It's a shelf tag labeling system, which helps shoppers make healthy choices without reading labels and that sort of thing. So it's pretty easy to make healthy choices at Hannaford. But I'm wondering too about medically tailored meals. I know that someone going through stage 4 colon cancer treatment is going to have specific, dietary needs and issues beyond just, thinking about preventing colon cancer. So once somebody already has colon cancer, we know that there are lifelong habits that have gone into sort of creating the underlying nutritional deficiencies that may have contributed to that. And so changing those things is complicated and takes years of practice and hard work to sort of, and his wife just died, right? So who's cooking for him? So I'm sure the dietitian will address some of these issues, but medically tailored meals is something that has been really, really helpful for people in this type of position where, if they can have a delivery service deliver some meals. And there are some resources around in some demonstration areas around Maine. And I don't know if one of them is in Augusta or not, but that would be an interesting resource to investigate.
Thank you. I think the team got more tasks. This is really useful because, in Maine, from the last census, 11% of the population is veteran. So if you're planning on practicing in Maine, you're going to encounter a lot of veteran as well. So thank you. I see some names.
Hi, everyone. So my name is Deng Yu Mei. I'm a first-year comm student.
Hi, my name is Macy Punzalan. I'm a third-year dental medicine student.
And my name's Alexandra, and I am a second-year physical therapy student.
So today we're presenting for the public health interprofessional training, and our case is a patient with stroke in rural Maine. So Antonio Garcia is a 54-year-old Hispanic male construction worker who presents with right-sided MCA-CVA secondary to macrovascular diabetes complications.
So here's our case framework. We have the individual, family, friends, community, and environment factors. On the left, we have the risk factors. On the right, we have the protective factors. And for there's many factors involved in this case, but our main focus on the one that highlighted, and we will have intervention that interrogate those. We have the modifiable for individuals, including high-fat diets, limited exercise, and some comorbidities, and other demographic. And we also have demographic and socioeconomic status factors, such as he's Hispanic, he's only have community college education, and he's low income. And for family and friends, he has a chronic ill mom that require a lot of caregiving, but he has no siblings to help around. In community factors, we have he has a dental office close by, but the hours is limited, so he doesn't get to see the dentist often. And he also has previous negative experience in healthcare, so that hinder him from seeking for help. And there's this, the closest stroke specialty clinic is important, so it's quite far away. And the entire family only have one car, so it's hard for him to get around, and there's no public transportation accessible.
So potential interventions that we came up with was to first limit the cost of healthcare for him by utilizing telehealth, patient portal messaging, direct primary care options, and dental therapist options. We want to limit the cost of his prescriptions through resources in the community. We want to get a dietitian or nutritionist to provide resources to learn more about a well-balanced diet and exercise. And we want to set up social work connections to discuss his previous negative experiences with healthcare and connect him with state resources such as long-term disability to help make up for the lost income since he won't be back to work. We also want to have him set up with home health nursing for both himself and his ill mother, and then set up with an RTP United Way ride system to help him get to his doctor's appointments or the grocery store. And that is our framework.
All right. Thank you for the presentation. Actually, your team is somewhat unique out of the 4 team. You are the only one that has a dental student in our team. So I would like to, ask from both sides. Students not from a dental program, how do you feel working with a dental student? And then Macy, how you feel with working with the other health profession. You are the only case actually had a dental issues listed for the patient.
It was super cool working with a dental student because she brought up a lot of really good points in our case. And, I think that a lot of the stuff that we came up with, she was able to tie into dental health and dental medicine. So it was really rewarding.
I enjoyed seeing how our professions could overlap in care. So it was really great working with everyone from other professions as well.
And I'm sure you all know that dental issues could lead to cardiovascular issues. So now you actually get connected and work on this. One thing I do want to ask you, Macy, how do you know which town has the water that already fluoride treated? Is that something as a dental student you would just know?
So we actually had to look up different cities and if their water was treated with fluoride. So we made sure that his city was. Yeah.
So there is a public resources that people could find out.
I'll ask a question. I was impressed with your attention to cost, with your attention to really thinking about how this gentleman was going to be able to not only navigate the medical aspects of what he was dealing with, but the cost as well. And I also noticed that you were not scrimping, so to speak, on the quality of the care you were putting together for him. So it made me think about something called the triple aim, which is out there in the universe. And I'm wondering if that was something you considered when you were conceptualizing the case, as well as the broader public health schema that you put together. Was that too complicated? Anyway, just respond however you'd like.
I'm not sure how to answer that question, but in terms of the quality of care that we developed, when developing this case, we realized that we had developed a really unfortunate case with a lot of health disparities. And so I think a big challenge for us was researching these different assistance programs for, people who aren't able to afford their prescriptions or don't have access to a good, inpatient rehabilitation hospital for stroke. So, in terms of like the quality of care, I think that it was really rewarding to all of us to, find these programs that we usually wouldn't, think to look at. So I don't know if Jenny has anything else to add, or Macy.
Yeah, just for our patient, because we do have a lot of like risk factors for him, but in general, he has good family support. So our main focus just shift from the relationship stuff and to like the care, what resource we can give him, and what type like resource to decrease the cost for him, all that. So I think we did a good job is we try to put different aspect from the dental aspect, from like physical therapist aspect, also like even for the relationship between him and the doctors, because he has like negative experience with other physicians that like he didn't want to seek for help. And that's also a main focus for our case.
Really good. I know we have to move on to the next case, a presentation, but I just want to kind of leave a question for the audience. Compare the last case and this case, both are, older gentlemen and have health issues, but they have a very different sort of a characteristics. They're different a race, ethnicity group, and a different living environment and different resources, even the insurance, one had a TRICARE and then one only have a MaineCare. So just kind of leave the question for the audience to think about it. When you see the patient, the medical problem is not the only problem. There are a lot of issues you have to look into and to think about it. All right, we can move on to the next presentation.
We also have an extended discussion at the end of this. So Mike Sheldon, I saw you raised your hand. Definitely hold on to your question for the end when you can ask any group about questions you had throughout the discussion.
Great, Megan. So team 4, if you would like to introduce yourself before we start the recording.
Hi, my name is John Kaminsky. I'm a physical therapy student.
Hi, I'm Kaylee Dixon. I am an osteopathic medicine student.
I'm Camille Mulcahy. I'm also a comm student.
I'm Lacey Reed, and I'm an undergraduate public health major.
This case is brought to you by the following students as part of the Public Health Problem Solving and Interprofessional Teams program. In this case, we will discuss the management of a 56-year-old male 3 days post-stroke, as well as some other complications regarding his case. In this presentation, we will discuss the patient's background, a variety of risk factors, protective factors, and the interventions designed to address his impairments, as well as the healthcare team required for those interventions. This is a visual framework we will use to organize this case. As we proceed, we will populate the boxes with the information that we discuss, so we can visualize the relationships among the factors of this case.
Mr. Lopez is a 56-year-old Hispanic male living in Portland, Maine. He was brought to the emergency room by his neighbor where he presented with left-sided weakness and dysmetria, left eye ptosis, and impaired balance with asymmetrical posturing. He was admitted to the stroke unit for 3 days and then transferred to inpatient rehabilitation. Mr. Lopez has been laid off from his job as a nighttime security guard due to his hospitalization and residual effects of the stroke, including left side impairments and movement deficits. His wife passed away 2 years ago due to surgical complications and has one child that lives close with whom he has a good relationship with, and one child that has moved away. His father passed away at age 60 due to a stroke, and his mother is living in an assisted living facility where he visits her approximately once a month.
For Mr. Lopez's risk factors, we first began by identifying those that were related to his health status and determining which were modifiable versus those that were not modifiable. For modifiable health status, he had a history of obesity with a BMI of 32, type 2 diabetes, hypertension, hyperlipidemia, and obstructive sleep apnea. These conditions are all able to be managed via compliance with prescribed medications, diet changes, and regular follow-up with appropriate providers. He additionally reported a diagnosis of depression, which onset 2 years ago following the death of his wife. This is also a health status that can be managed via prescribed medications, as well as therapy as needed. The aspects of Mr. Lopez's health status that were not modifiable included his age of 56 years, as well as his family history of stroke. Next, we evaluated Mr. Lopez's risk factors in regards to his behaviors. Our assessment concluded that his diet consisted of mainly fast food, and he was a regular tobacco user with a 40-pack-year smoking history. He additionally reported alcohol consumption primarily on the weekends, however described heavy consumption at 6+ beers each day during the weekend. Mr. Lopez also reported that he lacked any regular exercise routine, including light activities such as walking. These are additional risk factors that will need to be addressed as our team continues to work with Mr. Lopez.
Some of Mr. Lopez's risk factors within his working and living conditions include recently getting laid off from his job. His highest education obtained was his GED at age 28, and within his local neighborhood, it's considered less safe conditions for walking. Mr. Lopez's protective factors within his personal include insight of health concerns triggered by his recent CBA with new motivation. He has access to a vehicle, and he has history of physical activity. Within his social protective factors, he has a healthy local son able to assist. He has a supportive neighbor. And within his environmental protective factors, he has public transit available, a nearby grocery store, so access to healthy food, and an elevator in his apartment.
The healthcare team will be focused on the following interventions: acquiring main care coverage, assess expected functional outcome, and establish appropriate discharge plans, the coordination of social resources for discharge, monitoring of vitals, physical and occupational rehabilitation and education, pharmacological consultation, mental health screening, substance use counseling, securing unemployment benefits, and dietary education. The healthcare team will consist of the following professionals: this team and Mr. Lopez thank you for your time and attention to this brief discussion of Mr. Lopez's case.
Very impressive presentations. All right, we're open up for questions.
Okay, so very nice job. The others did a great job too. So I am wondering whether you had considered, since social activity is such an important protective factor, whether there might be a way to connect Mr. Lopez to some virtual activities, since he is kind of, has limited mobility, although he does have a car, et cetera. I mean, with his wife being deceased, I'm wondering if there might be a way to connect him with activities that might be fun for him.
Well, that isn't something that we had considered. That is interesting, especially considering how difficult transportation would be, having to move around the bus schedule and whatnot. Yeah, we'd have to know what his internet access was like, whether or not he had internet access at home, public availability of internet. I know that some downtowns have free Wi-Fi. Public libraries are also an option, either for Wi-Fi or use of computers at their facility. So it definitely would be probably fairly easy, if you're looking to engage in some sort of online community, just finding time to get down to the public library, if that is the only available option, is certainly possible with the public transportation system. So it would have to definitely depend on how important that is to Mr. Lopez, as well as whether or not there are communities online relevant to his interests, which there probably are, because the internet's kind of big.
It is kind of big. I noticed his depression as recent onset of depression, so I thought that might be a way to help.
Good afternoon, team. I have two what I think somewhat related questions. My name is Mike Sheldon. I'm the Associate Provost for Academic Affairs. I'm curious, in your plan, you had monitoring vitals, and I'm wondering about your thoughts on the use of telemonitoring, not just the vital signs, but other things that you have in your plan. And also, the team is a pretty big team because this is a fairly complex case. Your thoughts about the platform, communication platform you'd be using to help facilitate really good coordinated conversation between the team members going forward.
With respect to the vital monitoring, I think our thoughts were mostly in inpatient care. You'd need monitoring of vitals in order to facilitate the administration of care from other providers, just to make sure that you don't cause any vital system failure or complications otherwise. But if anybody else has anything to add regarding vital monitoring at home, that would be interesting. I know that it is possible. I've heard from some nurses that do this sort of thing.
When it comes to vital monitoring at home, I do think it's an option. I think that in order to accurately do that, we need to teach Mr. Lopez how to accurately take his blood pressure, because I know that some of the at-home blood pressure cuffs can be, depending on who's using them, you have to give them that education because they can get false readings, and then that can cause stress to them, and that can go down a whole different pathway. So I think just the main thing with that would be educating the patient on how to properly do it, considering them like sitting down, not after they just walked upstairs. They need to have like rested. Anyone else have anything to say?
So what about a team communication? The second question.
I mean, off the top of my head, I'm thinking phone calls, email. I'm not sure exactly what would be different in this sort of situation. I know that if there was home care provided, some co-treatments would be possible so that you'd be able to communicate at the site of care. But if anyone else has anything to add, I'd be interested in hearing that. Also, if someone asking the question might be interested in maybe explaining some of their thoughts.
You do have a case manager, right, in your team. So you probably the case manager would be a somewhat a team leader in your care team, and you would have regular schedules, I think, for meetings, reportings, and all set up all those kind of structures for the care.
And I don't mean to put him on the spot, but I'm going to put Dr. Muser on the seat, because he's worked with, and I have too, a little bit, with a company that actually does some of this remote monitoring and helps to coordinate transmission of information and sends up flares. To the point about the blood pressure readings, if there's an irregularity over time, it sends a flare up. And you can, and it contacts to the appropriate provider who might need to know that. So Tom, I don't know if in a quick snapshot, if you could speak to, I know you know what I'm speaking about, but if you could just give a couple of comments about that.
Thank you, Mike. Yeah, you're referring to something called Sensio Systems, which is a organization that really attempts to, on a specialist monitoring level, kind of help primary care providers do a better job through digital monitoring of their patients in their homes. And so the patient must agree to have this monitoring system installed and learn how to use it. But the benefit is that it catches things early. And it's not that the care is provided by Sensio, but they facilitate care then provided by the regular clinician. So this kind of monitoring, I think, is going to be really interesting as it is linked to artificial intelligence, which might notice patterns even sooner than a clinician might. So anyway, I hope that helps.
Do we know any of these system being covered by insurance, or this is a main care? Would it be cover some of these services?
I know Sensio has found a way to bill for services, but I couldn't give you specifics on that.
Mm-hmm. Yeah.
And I do believe that Medicare does cover a fair amount of RPM in terms of sending patients home to do self-monitoring.
Mm-hmm. This is really good to know. And I think this is also going back to patient-centered care. A lot of the things as a provider, you might not know what resources are available or not available. And to really care your patient, not just suggesting things that has to be done, but also help to find out how this can be done. I'm sorry. We're in the open question phase, open discussion. So anybody have any remaining questions and comments, just feel free.
I'd like to just deviate a little bit from AI, if that's okay, Dr. Sheldon. I know Dr. Polachek brought up also the behavioral health component of this. This is a gentleman who is experiencing at least what seems to be situational depression, but I also notice in your list of interventions, you talked about substance use counseling. And so I have a question about cultural considerations in working with this gentleman around mental health, substance use interventions. Is there some thinking that went into the cultural aspects of working with him?
As far as I know, we didn't really think about any sort of cultural considerations. That was just one part of this case that we didn't really develop, sort of. But I think as long as you approach something like that in a very open-ended sort of way, any cultural considerations or barriers or other factors will reveal themselves in, for example, a motivational interview style of, you know, we've noticed you have these sort of habits, and I want you to know that these are things that can impact some of these outcomes. Is that something that you'd like to talk more about? Because we can consider this, this, this. Do you have any interest? And if they don't, you could ask why. If it's a cultural reason, that'll reveal itself. Otherwise, yeah, we can proceed. So I think that with the right amount of openness, you don't have to necessarily prepare for all possibilities, and cultural considerations being one of them. It's just about being open and being comfortable asking why, and maybe also just being comfortable with not having some answers for things.
Maybe team 2 want to chime in as well. So both of your patient has a Hispanic origin. And also I remember one of your cases, the patient did not want to go to the doctor because the doctor does not speak their language, had hesitation to get regular care.
Yeah, so for us, our patients primarily speak Spanish. He went to community college and get some language training, but he still prefers speak Spanish. So for him, our focus will be using a interpreter, an interpreter, as have someone help to translate throughout the process. Also, we need to know how well can he communicate online. How can he type out the English word? Can he communicate on phone? So those will be the aspect we need to all consider it.
So one question I want to ask all team members or anybody here. So in our program, we mentioned that Maine has a 211 you can dial and to get resources. I don't know if anybody have tried that to help your patient to get resources, or anyone else have any comments about 211. If you ever used it or have any experience.
I've used it personally, and I've been a primary care provider for 10 years. And unfortunately, I think some of the funding for it had decreased maybe about 3 to 4 years ago. But it's still a solid place to start if you really have no idea where to go. And my hopes are that line will get more robust again. When I first started, it was very robust and there were a lot of answers. And then, like I said, around 3 or 4 years ago, it kind of declined a little bit. But my hope is that will turn around.
Thank you.
So I've been asked to say that we're come to the end of this amazing poster session. Thank you, students. You are amazing and you give me such hope for the future. Thank you so much for your fine work. For attendees, thank you for being here. And for those of us who are part of this roadshow, we're going to meet back in the main room in just a minute. So thank you all so very much, and have a great day.